I'll just start with some introductions. And again, my name is Chris Bruni. I'm the Vice President of Sales for Security Health Plan. Our Wednesday webinar series are a joint venture brought to you from Security Health Plan and the Marshfield Clinic Health System. We are here to hopefully inform you of a lot of things that are going on. We've had a lot of focus in this last year on COVID, and so I'm very happy that we're not focusing on that today, that we've got a different topic at hand. And we're very, very pleased to have you with us today, Jeron. I'll give you an introduction in just a couple of seconds as I get through some of my other administrative things here. So we do have a Q&A feature and a chat feature that's in the upper right-hand corner of your screen. For anybody that does want to ask us a question between Jen and I, we will be monitoring those questions throughout Jeron's presentation, and we'll make sure we get to them before the end of the day. If there are so many questions that we can't get through them all, we'll make sure we address those and get those out to everybody in the meeting notes that Jen will send out likely tomorrow. So again, this presentation is being recorded. Jen will post this on the Security Health Plan website under our employer section under our COVID page. So if you go to our COVID-19 page, you'll see several tabs there. There's an employer tab, and you'll see this presentation, as well as all of the other ones that we've done over this past year for the Wednesday webinar series, and feel free to peruse all of them at your leisure. This presentation, for anybody that did pre-register, will be sent out. As I said earlier, Jen will get that out to you likely by tomorrow. And if you have any follow-up questions after that, we certainly want to hear from you. And again, there'll be a survey that goes out later as well. So please tell us what you think. And other topics that you want to hear more about, so that we can get those queued up for future Wednesday webinars. So without further ado, I'm going to go ahead and introduce you now, Jeron, and we'll get the baton handed off to you so we can hear all that you have to say about cancer care and what's going on at Marshfield Clinic related to that. So Jeron Jackson is a Master's of Health Administration, works with the Marshfield Clinic Health System as our Service Line Administrator for Oncology and Cancer Care and Research, and musculoskeletal orthopedic services for our clinics and different programs and inpatient units throughout the Marshfield Clinic footprint. This includes the Western Wisconsin and our bone marrow transplant area as well. He's had the opportunity and worked with us to design and build multiple cancer centers, which is great, and is a huge proponent of our patient-centered care. He got his degree, or his master's degree, from Pacific University, bachelor's from Brigham Young, both fine institutions. And prior to his work with the clinic, worked for Banner Health and SCL Health Systems in Colorado, with operational focuses in cancer care and surgical services and gastroenterology. So he's been an adjunct professor at Pacific University in Oregon for the past 6 years. So he's very used to doing these kinds of presentations, so we're looking forward to that. And he's a board member for ENC, Everyone Needs a Community, a nonprofit developing sustainable housing for individuals with autism and seniors. Great work that organization does as well. So very heavily involved in the Wisconsin Cancer Care Collaborative, on the policy committee seeking to impact cancer care throughout the state of Wisconsin. You're also a Scoutmaster, and you serve in Rotary. You got a wife and 4 kids. I mean, my gosh, you got a lot going on. So we're very pleased to have you, Jeron, to talk to us today. And without any further ado, now I will hand the baton off to you. So thank you, Jeron. Take it away.
Thanks, Chris. All right. So today I kind of want to hit on a few things with you guys today. Obviously, we want to talk about the program, but start off with the cancer patient journey. Kind of go into the Marshfield Clinic Cancer Care and Research services, and kind of what we're offering, but also some of the things that we're doing to decrease cost of care, provide access throughout this half of the state, and talk about some of the things that are on the horizon for cancer care in general. So this year, just to be frank, it's been a wild year. And when everything shut down at the beginning of COVID back in March, the one thing we did not shut down were cancer care services. So we had to kind of redesign how we function in real time to best meet our patients' needs there. So we did not stop doing that. So that's created its own challenges, but people have been amazing and adaptable. We've had chemo nurses that have volunteered. We had one of our chemo nurses from Stevens Point that volunteered in New York at the height of at the beginning of COVID over there, and she's and multiple staff that have done the same thing throughout the system here over the last couple of months during our surge here. So, yeah, it's been a remarkable thing. But cancer doesn't wait, and that's the thing. Even in spite of COVID and everything else, things are still going on. So one thing to be watchful of as employers is the fact that during COVID, there's a lot of patients that have avoided screenings, avoided procedures, avoided access things that they typically would have done that would identify cancer sooner. So, actual diagnoses across the country are down. There was a Wall Street Journal article on this here recently, and the cancer's still there. It's still coming. People have been hesitant to even go into the doctor, have been scared. So. I heard of a case here back in May where we had a patient that was not able to defecate for a couple of weeks, avoided coming to the ER, and then finally, when she showed up, she had stage 4 colon cancer. So it's an example of the fears of COVID and some of the downstream effects of this. And so I think over the next couple of years, as we're kind of resetting, all your businesses and healthcare, we're going to be experiencing the downstream effects of this for quite some time. So I kind of want to start off here regarding the patient journey. So obviously our organization, our mission is to enrich lives through accessible, affordable, and compassionate healthcare with our communities. And our Cancer Center program, obviously is committed to that. So I'm going to walk through here, through the cancer care journey. I'm going to talk a little bit more about access and hit a few different services and some takeaways and stuff here. And at the end, with a couple minutes left, communication afterwards, please feel free to reach out. I want to get your feedback about what we can continue to do to support your employees that are going through cancer. I think that's the thing is people don't realize that a lot of your employees that when they have cancer, they're still working if they can. The impact of the financial toxicity, which we'll talk a little bit more about, which is the high cost of care and the impact there. I mean, it's very, very difficult. So I had to experience this firsthand. About 20 years ago, 25 years ago, when I was in high school, my mom was diagnosed with ovarian cancer, and she had that battle for about 5 years. And while she was going through that, my family, we tried all kinds of interventions during that time, clinical trials and whatnot. And it nearly broke us. This is before the time of previous conditions and coverage there. So my mom was, near. I mean, she should not have been working, but she was forcing herself to go to work and to travel for that. And my family didn't always have food on the table, and it was a rough. I got to see firsthand the impact of this, from a very personal standpoint. So, I think that we are in a better spot to take care of our patients now than we were even back then. I think our outcomes have improved quite a bit. If she were alive today and had the same disease, she would likely be able to conquer this thing. The innovations that have occurred over the last 20 years within oncology and cancer care have been tremendous. So, we're going to kind of dive into that. But as you know, when you get that diagnosis, it's a life-changing experience, and puts things in perspective. Cancer patients are some of the most amazing people I've ever met. I mean, everybody knows someone that's gone through this, and not everybody handles it the same way, obviously, but more often than not, I've been amazed at the focus and the kindness and the inspiration that occurs here. This is an infographic that I kind of want to share. There's a few points in here that I kind of want to point out that we're starting to see in the industry. So most patients are getting their information from looking up their information online when they're getting diagnosed or when they're getting symptoms. Everybody's Googling, right? And now the majority of them are going to to hospital specific websites and whatnot. There's but a lot of patients, they're asking their family, their friends, they're obviously contacting their insurance company to see if they're going to be able to pay for things. On average, though, 28% found a different doctor specializing in their care. They will change providers in order to get the right care, and that is so about 11% at some point have changed providers during their treatment. 23% said that they wanted more different treatment options, and 20% just wanted better customer service. So there's obviously room for improvement here. One of the things here that the things that patients are asking for, additional better symptom management. We'll kind of talk about what we're doing in Marshfield to address that. Having all their care in one place, in one cancer center. We have 6 cancer centers across the state. And so we've attempted to do that as well. Multidisciplinary care, we're going to talk about that. That's the other piece here. And then one person to answer your questions. We have support services, support staff that really kind of hone in on this. And then online portal to view your tests and contact your team, which we have. Additional support services. This is an area that we need to kind of get into over time. It's interesting. 75% of them said they wanted relaxation therapies. We do have with Dr. Jen Michaels here in Marshfield. She is a psychologist here who specializes in mindfulness and in therapies and cancer treatments specifically. And those types of techniques and those types of things, it's interesting the demand for those things. And the last piece here that it's kind of showing the full, there's the after treatments of the survivorship. We're getting more and more people that are coming through this and getting on the other side, and our survival rates are increasing. But the questions kind of go back to how do I watch this? How do I looking for signs of reoccurrence? What am I supposed to be doing what do I look at the physical side effects, the mental side effects, emotional side effects of this? And we're going to kind of talk a little bit about that, and that kind of goes back to support groups and whatnot. So going back to the beginning here, so an important thing to invest in always is screening. So the sooner we get it, the better, right? Mobile screenings, for example, in Marshfield, we've actually had our mobile mammography and bone density program in place since 1999. We see more than 6,000 patients a year. We visit underserved areas, migrant camps, et cetera. And we've also partnered with various businesses for screening events for employees over the years. As things are kind of picking up again, this may be something that you may be interested in reaching out on again. These events, on average, we were doing about 20 events a year prior to COVID, and you can see the on average, the screenings and the diagnostic exams that were coming in there that we were bringing on site to these locations. So a little bit about Marshfield Clinic Health System. Our cancer care program has been around since 1955, which is really early on from a cancer standpoint, and from some of the work that started there, the early days of chemotherapy and whatnot. We treat about 13,000 patients in the last 12 months. We have about 3,000 new patients per year in our program. We mentioned obviously the 6 main cancer centers, which are Marshfield, Weston, Stevens Point, Minocqua, Eau Claire, and Rice Lake. We have outlying sites, as you can see on the map there, where we're doing outreach and also chemo in a lot of cases. But those 6 main centers all have linear accelerators and radiation oncology services as well. Obviously, 17 medical oncologists, 9 nurse practitioners, robust radiation oncology program with medical physicists, dosimetrists. Dosimetrists are the folks that actually do they're actually designing the treatment plans with the software. In addition, Marshfield Clinic in the region has one of the best. We have specific subspecialists in oncology that don't exist throughout the state. So we have 3 board certified surgical oncologists. They're the only ones outside of the Milwaukee and Madison areas. We have a gynecological oncologist, only one in the region. We have a neuro-oncologist. There's only a couple in the state. We also have a couple of 2 pediatric oncologists. We have a pediatric program as well. We have we established a women's intimacy clinic in 2018 with a cancer focus as well. It's based out of Weston. We have the only bone marrow transplant program in this region. I think there's one in Green Bay. There's a couple in the Milwaukee area, and the main one's obviously at Freighter and at UW. So, and we were the first accredited bone marrow transplant program. We are an autogenic program, not an allo program. So an auto means those stem cells are coming from your body, not from a donor. So we do not do the allos. The allos are those are fewer cases. So we typically send those to Freighter or to UW or to Mayo. In addition, we have one of the best specialized acute inpatient units in the region. 8 North is a fantastic group of nurses, and they well trained, ability to handle acute leukemics and others as well. The reason why, so recruiting specialists is difficult in general to rural areas, as we know. We have, there's physician shortages, nursing shortages. I think that's all kind of been increased from a pain standpoint by COVID. But here's the thing: before all this, by the year 2030, cancer will be the leading cause of death in the United States. It's predicted that it's going to pass heart disease as the #1 killer for Americans, as you can see up here. Part of that's got to do with the aging population, but yeah. So this is, even as of 2014, 22 states have more deaths from cancer than heart disease. So this is we're going to see more cases of this, and as your employees work later in life, you're going to have more employees that are fighting these battles as well. I kind of hit on the physician shortages nationwide. So recruitment's been really competitive, not enough residencies. Oncology staff, that's a challenge too. And the other piece I mentioned about survivorship, we're going to have over 20 million cancer survivors in the US by the year 2026. People are living longer due to better treatment. The cancers can be detected earlier and easier. And then obviously, a challenge with all that is, with an aging population, you have a Medicare percentage that, if the payer mix that continues to grow. So, and then obviously, quantity leading to quality. I mean, I think the more cases that's why you see so few subspecialists, because you want, if every cancer center had a surgical oncologist or a gynecological oncologist, you're just not going to have the quality outcomes because you're not treating as much, right? So that's why we have centralized those folks in Marshfield or in Eau Claire. We do outreach as well to other sites. So this is going to hit you guys home a little more right here. So obviously, we're expecting by 2035 a 44% increase in cancer incidence. I think within the next 5 years, we're expecting another 25% in the region. A part of this is going to be also an increase in cancer costs. You look over the last, from 2004 to 2014, 36% increase just in Medicare, 63% increase for commercially insured. That's heavy. So so how do we kind of rein some of this in? And let me kind of walk in through a couple of things here. So first off, we'll put the patient first. Our cancer care and research program is, we've developed a culture of yes, from our physicians to our staff to the person that's checking you at the front desk. We will get any urgent consult in within 24 to 48 hours. That is standing for cancer care, and we've set that standard across the board. We have nurse practitioners that we utilize as well, allied providers that help us to see those walk-in patients, kind of triage them and get them in right away. No one should have to wait to have these kind of discussions, right? And so that is something we're committed to and moving forward. Allied providers or nurse practitioners The utilization of them is kind of changing in the industry. I mean, 25 years ago, you didn't see NPs or NPs specifically utilized like you do now. In oncology, they are not independently practicing. They really kind of follow a team model. So they're handling the treatments, like your chemo treatments, your radiation treatments, all those things. They're going to be planned by the physician. But like some of your day-to-day work might be with a nurse practitioner. You might be, which is good. I mean, they're able to kind of follow you along that way. Another thing about Marshfield that I think that's a huge support here is we have really good radiology, really good pathology lab support, services, genetic support. We have those services have really helped us in keeping those all on site here. Including lab, and I think I talked about it a little later on. Other health systems are sending some of their complex lab work out to Oklahoma or other states and stuff. We're able to flip that around here on site in Marshfield in the heart of Wisconsin pretty quickly. Telehealth is something we had started doing even prior to COVID, but now obviously everyone's doing it, and we're doing it. We've increased our between phone care and telehealth over these last few months. We have 3 genetic counselors as well, and and some of other there's other systems around the country that are pretty robust in telehealth as well. We have a 24/7 oncology triage line that frees up our providers, by staff certified, but also it avoids unnecessary ER visits. It's really convenient for the patient. They're able to talk to a chemo nurse that understands their stuff as opposed to just going to the OR right into the ER. So that is a piece that we've had in place for about 10 years now. It is not a standard in most services, and I think it's been a nice boon for our program for our patients. There's pharmacy access challenges, drug shortages, drug costs, staffing costs, step therapy. Step therapy is when a payer says, like, "Hey, we're not going to pay for this chemo or this drug until you fail on all these other drugs." So those are some of the challenges we face when we're working with them right now. And so that's why I'm going to talk a little bit more about the need for precision medicine and genetic testing and genomic sequencing. Those are pieces that really tie in and allow you to get right to the drug you need to get to right away or the right treatment. Part of the solutions we've had with pharmacy, we've actually utilized telehealth services for years, for almost 20 years with our pharm techs. We have an oncology pharmaceutical therapeutics committee where we're reviewing all new drugs. We're going through drug shortages. We're going through biosimilars. We encourage our physicians to use the cheaper drugs to drive down the cost of care for those patients there. And then we have our Marshfield Specialty Pharmacy, which has been fantastic to have on site. And once I said, I think labs are all local. Radiation treatments. We have the only gamma knife in this half of the state. We have 2 HDR high dose rate brachytherapy suites in both Marshfield and Point. And then we utilize the TrueBeam, variant TrueBeam Linux linear accelerators. These are the machines that we use for radiation treatment. And we've tried to establish and standardize those machines and software across the board. We also have, with surgical oncology, we have a HIPEC program. We've got pancreatic cancer screening program as well. And obviously you can see the 3 of the cancer centers that we've built over the last couple of years. We are accredited by multiple bodies. We're the only ASCO COPI accredited program in the state. That is a gold standard for chemo quality. We are FACT accredited for our bone marrow transplant program. We have 3 different NAPDC breast centers, nationally accredited breast centers, as well. So, kind of the piece about genetic testing, genomic sequencing. These things are really important, and coverage is needed with this. When you're working with your payers and when you're working on your benefits packages, make sure that these pieces are included, because this is going to get them the right care they need at the right time. Because it impacts precision medicine, it impacts the immunotherapies they might get, the biologics they might get, or the chemo they might get, and even some of the radiation. So it gets us more accurate. The data helps us moving things forward, and so that's really essential. We have 3 genetic counselors on site handling regular genetic testing, but we also we do send out for more complex genomic sequencing, to a few different vendors in the region. And another thing that from a coverage standpoint for payers, coverage for second opinions. I think that's a crucial piece. I mean, we're not afraid to send out, and whether it's here or within our organization or someplace else, I think it's really important that they have that option because to have those discussions because really key. So our bone marrow transplant program we kind of hit on already. CAR T is a program we're setting up right now, and it's kind of at the intersection, right, as you see, like cellular therapy is where kind of CAR T is at. Gene therapy we've already kind of had going on, and immunotherapy. This is a kind of a combination of all three of those, and we're rolling this program out within the next year. Right now, it's only available at UW and at Freighted or Mayo. It's essentially that you're taking the body's T cells and the immune system, you remove them through an apheresis, and then just like you would with a transplant, bone marrow transplant, and then you apply this CAR T cell drug to them, and then essentially process it, and then you send that you infuse those cells back into the body, and they go and attack the cancer cells. It's pretty insane. There's literally hundreds of these CAR T treatments that are in the clinical line pipelines, and we're working with some of these right here. These are treatments that have research that's happened very, very quickly. It's actually based on a lot of the work that around the immune system, based on AIDS. It's pretty crazy how quickly this has kind of evolved. The responses have been pretty intense. So Yescarta, which is the one we're working on right now, there's a 72% positive response. 51% of the patients had complete remission, and these are third and fourth line. So they've been on 3 or 4 different chemos or treatments, and they failed them all, and half of those were completely cured. When they did it with children, I think it was like a 90%. So yeah, there's plenty of stuff coming up. The issue with CAR T is the cost. It's a high cost drug. It's about $373,000 a dose for the patient there. So these are things, and there's intensive ICU stays and stuff with this as well. So that's the challenge. It's like the more precise we get, the more expensive some of these get, and how do we balance some of this out, and making sure that things get the right stuff. Part of that goes back to quality. So we have multi-specialty tumor conferences, head and neck, GI, breast, lung nodules, etc. Those are there, and we have you have teams of multiple physicians working on and having these discussions so that you're able to find the best possible outcome, and you're questioning each other. I kind of mentioned some of the accreditation standards that are supported, including COPE and others. They are resource and time intensive for programs. However, I think they're a must-have. I mean, it's all about safety and quality for the patient. So. I think we'd already kind of we also developed an oncology clinical practice committee where we have frontline nursing staff and pharmacy, kind of developing best practices and benefits from there. Clinical trials, we Marshfield Clinic Cancer Care and Research Program. We are part of an NCORP collaboration, which is part of the NCI, the National Cancer Institute, which is part of the NIH. And a couple of years ago, we had a reset on our program, and we've since partnered with Gunderson and ThedaCare. We were the 3rd top accruing program in the country last year. And Dr. Antillo, our medical director out of Weston and Stevens Point, he was the top accruing physician in the entire country. And we had multiple physicians that were on the top of that list. So we've really strived to integrate clinical trials into our program. I mean, if we want to give people access to the best care, we need to give them access to everything that's going on here. So additional support service, I kind of talked about who you're contacting. We have navigators, we have social workers, we have behavioral health, rehab services, survivorship programs, support groups. These are all important pieces. Another piece though goes back to travel, lodging. So I worked with the state here recently. We helped pass some legislation back in February, right before COVID hit. Probably one of the last bipartisan things that we did in the state house here. but it was to kind of to free things up so that like cancer trials could actually we could actually pay for food and lodging and travel by clinical trials groups, because that's really about access. It's not about incentivizing someone to do a clinical trial or whatever. It's about doing the right thing, get people access that they need. In addition, we have our Cattails Cottage here in Marshfield, which is 11 beds, and we provide lodging for cancer patients from the UP all the way throughout the region as well. So we've developed robust volunteer programs and telehealth as well. Financial toxicity. Where are we at on time, Chris?
We're well into the time that we had, so we're pretty much up against the clock.
Okay, I'll hustle through. So financial toxicity, so the high cost of care. So obviously drugs, tech, it's continuing to increase. 80%, cancer patients have an 80% greater risk of mortality when they're bankrupt compared to those who don't. And then in general, cancer patients are 2.5 times more likely to declare bankruptcy than people without cancer. This is a serious thing. So part of it, we try to get our prior authorization stuff streamlined. We've also worked with drug companies to find rebates and other things. But this is a very, very real issue. So as you can see, in addition to that, cancer patients are 4 times more likely than the regular population to be depressed. These are real issues here. So as you can see, the cost not related to treatment, job loss, subsequent loss of insurance, child and elder care, cosmetic items, wigs, and some payers will pay for that, but not all. Transportation and lodging, So these are all things, and if you don't have that, people could skip medications. They might not be getting the food they need. That there's a lot of things that kind of lie up here. So I had so much other goodies here that I would like to get into, but I ultimately, we have engaged with hotels and restaurants for patients to make sure that they can get treatment farther from home, gas cards, local, mass transit. We've I kind of hit on some of the rebate stuff as well. And then CMS and the feds are working on different bundling proposals. We're not in this one right now, but like for radiation oncology, they're looking at bundled payments over the next couple of years as well. This is an issue I think that both Democrats and Republicans have talked about over the years of reining in the cost of care. It's just a very complicated issue, and so more than anything, I think we focus in on philanthropy and answering our patient care's needs. And then lastly, we've tried to get out. We've joined up with Buddy Check with Channel 7 and Channel 13 in Eau Claire, to work on breast cancer awareness, cancer care awareness, with our providers, and then there's a ton of events that we were at pre-COVID, and we're looking forward to getting back into when this thing all wraps up. So that's essentially what I had to share with you guys today. I'm kind of curious to hear if there's some questions. I didn't see anything pop up on the chat feature, but happy to answer any questions you might have.
Just one question, Jeron, and thank you. A lot of information there, and really appreciate you presenting today. But just one question: as an employer, how can they best help an employee that has either themselves going through the cancer treatment, or maybe a family member? What can an employer do to best help that employee?
I think making sure that they have coverage in their plans for some of those features I talked about before. I think genetic testing, genomic sequencing, second opinions, those things. But also, tie them to your EAP. And then, I think mental health support is pretty crucial in here. I mean, these are bombshell, things that they rock people's worlds, and finding what I don't know, but I mean, it's hard. I'm an employer too, right? So I get the challenge it is to kind of balance, the needs for the workplace versus that, but give your folks some flexibility. I mean, if they gotta, we try to get them in. Maybe that patient needs to see things, be seen, and get their chemo in the morning or earlier morning or in the later afternoon. And we're working on some things to, we talked about expanding that out and providing, so like in the hospital here in Marshfield, we can do some treatments and some things, on the weekends or later in the evening. So those are the types of things I would I would urge you just to, have some understanding there and work with them on that. And, here's the thing, it's not forever. I mean, treatments can last a few years. I got a close friend of mine here a colleague that I work with. She's, the last 6 months, she got re-diagnosed, back in June. And then, but she's clean now, and so like I covered for her stuff for a while. We all kind of pitched in and helped her out and gave her some flexibility, and she's doing great. So put people first, I guess.
Great answer. Great answer. Well, thank you very much. And thank you all for attending today. We're going to cut it off there because we're a little bit over our time. But Jeron, thanks again. Please come back and give us updates on things as you're developing more and more treatments, especially some of these new things. They really sound pretty exciting, pretty costly, but obviously, if we get much higher survival rates, it's worth it. So
yep.
Again, thanks everybody and be well.
Happy New Year, guys.